Good evening and welcome. My name is Lindsay Coate. I am the Vice President of Strategic Operations for the Sierra Sacramento Valley Medical Society. And I invite everyone that's on this evening to say hello in the chat with your name as well as your group and even your specialty if you'd like. We're so pleased that so many of you could join us this evening for SSVMS's Health Equity Committee Storytelling Webinar Series. Tonight, we are addressing access to care issues for LGBTQ+ patients. Tonight's presentation is recorded and it will be available on our YouTube channel on demand for CME credit through Wednesday, September 8th. Now, before we introduce our speakers, SSVMS's Health Equity Committee Chair, Dr. Bianca Roberts, would like to share a few words with you. Dr. Roberts?
Hi, thank you. First, I'm so excited that we're all here today. I know we're all really busy and with patient care and other things going on in our communities. I just wanted to kind of give a little bit of extra background about why we're here. Through SSVMS, we have developed a Health Equity Committee, and one of the focus areas that we've had for how we can further support the efforts of SSVMS is we wanted to provide resources to medical groups and develop best practices on addressing racism and bias in medicine. And really our focus has been on physician education, advocacy, and also doing community needs assessment. So this is part 2 of a 3-part webinar series. The first was on racism in medicine, which occurred in April. This one is focusing on LGBTQ access care. And our next webinar, when it's scheduled, is going to be about bias towards disabled patients. So we're just really happy to have our panelists here. I'm just ready to learn along with everyone here.
Thank you, Dr. Roberts. Now, please join me in welcoming Lexi Gutierrez to introduce our speakers tonight. Lexi is joining us today from Executech, a bronze level sponsor for SSVMS's Partners in Medicine program. Lexi?
Thank you, Lindsay. I am Lexi Gutierrez, and it's wonderful to be here tonight to support SSVMS and the medical community. I'd like to introduce our speakers today. We have Dr. Kim Mcilnay and Dr. Christopher Swales. Dr. Mcilnay has a history of taking her personal experiences and using them to help others. As a family physician, she had to retire because of her complications from multiple sclerosis. So she's become an independent patient care advocate for medically complex patients at Together Patient Advocates, LLC. So tonight, she'll be sharing another important personal experience. As a proud parent of a transgender teenager, she's seen the difficulties in navigating healthcare from the patient side. Dr. Swales is a primary care provider with the Woodland Clinic Medical Group, and as a member of the LGBTQ+ community, he sought out education that wasn't taught in medical school, gender-affirming care. He's taken his experiences and shared them with the Mercy Medical Group, with UC Davis, and now he's sharing them with you tonight. So welcome, Dr. Mcilnay and Dr. Swales, I apologize. Dr. Mcilnay, I believe you are up first.
So tonight, I'd like to share our experiences navigating healthcare with our transgender teen. This is our family, my husband, Josh, my son, Quinn, and they are here joining me tonight, and myself. Our story begins at Quinn's pediatric well child visit at age 13. I scheduled this visit with the explicit purpose of establishing an appointment or establishing a good relationship with his new pediatrician to allow for good anticipatory guidance for him. As we sat in the waiting room together and he filled out his extensive adolescent screening questionnaire, answering such questions as, was he drinking alcohol? Was he having sex? Was he having thoughts of self-harm? I wondered to myself what teenager would answer those questions honestly while sitting next to his parent in the waiting room. And we went back into the exam room and met with the pediatrician briefly. And I offered to leave the waiting room or leave the exam room so that she could speak with him privately. And she looked at the questionnaire and saw that he had answered no to all the questions. And she said, no, there's no need. He's a good kid. And so flash forward 6 months and he cut his hair short and he started purchasing his clothing from the men's section. He asked to wear a binder and I started noticing some symptoms of depression. And I asked him if he was depressed, and he said that he was. And I knew it was really important that we get him in to see his pediatrician quickly. But he no longer met her criteria for being a good kid. And in addition, he was now identifying as non-binary. And I didn't know if she would be supportive or how she would respond to that information. And it was critical to me that his first experience as a non-binary teenager at the doctor's office be a positive one and be affirming. So I sought support from a close friend in the medical field, and she was able to help us get in within a couple of days with a close friend of hers who was a very affirming pediatrician. So what we found went very well at this appointment. On arrival, there was a rainbow sticker on the wall of her exam room and on her badge that let us know she was affirming. She asked Quinn what his pronouns were, and she acknowledged her intention to use them correctly. When she made a mistake, she quickly corrected them and moved on. In contrast, at subsequent visits with other providers, he noticed that when mistakes were made, there would be a lot of over apologies made. And this over apology and sorries made him feel very uncomfortable and put him in the position of comforting the person who was apologizing. And that made him very uncomfortable. She addressed his mood concerns well and started him on medications for depression and offered him therapy for the stress regarding his gender dysphoria and the stress around his transition. She was very careful not to pathologize being transgender because being transgender is not a pathology. And she was familiar with area resources for gender health and placed a consult to the Gender Health Clinic. Over the next 2 weeks, Quinn came out to close family and friends. He felt an immediate sense of relief with the supportive response that he received. And with that acceptance, he realized he is actually trans male, and he was able to embrace his full identity. Over that summer, he spent the summers presenting as male, and he gained a tremendous confidence in being himself. This picture is taken from our summer trip to Canada, where he just glowed with joy every time one of the wait staff acknowledged him as dude or sir when they were serving him. Later that summer, we had a stressful time at the ER when he developed severe pelvic pain. And he experienced repeated misgendering over the course of that ER visit. As a physician parent, I had a lot of stress. We were dealing with pelvic pain. I didn't want the medical team to miss potential ovarian issues by masculine gendering, but I also wanted him correctly gendered. And then there was a power differential. I was afraid of irritating staff by repeatedly correcting them. And so when we got home after that night, I was very frustrated that I had not stood up for him more, and I resolved to do better at future appointments. At the ER follow-up with the covering provider, I introduced Quinn as male, and she referred to him as female, and I firmly corrected her. She continued to misgender him and continued to do so despite repeated corrections. And when we left, Quinn was very distraught, asking, was that a mistake or was she purposely misgendering me? And it really messes with my head when that happens. I can't stress how important it is to use the correct pronouns with your patients. Studies have been done that show immediately following an appointment where a patient is misgendered, there's an increase in self-harm risk and in suicidality. Following that summer living as himself, Quinn knew by the time that his fall consult to the Gender Health Clinic arrived that he wanted to start testosterone. So we embarked upon a series of 4 appointments to assess the appropriateness for hormone therapy. What this clinic did well, on arrival, the intake forms had multiple options for gender identity, including fill in the blank. The family medicine staff was supportive and affirming throughout. This was a safe space for Quinn where he knew he was accepted for who he is. And I noticed that he was not on guard during these appointments or worried about being misgendered or judged. He was relaxed and comfortable in himself. All language was neutral instead of gendered. For example, his doctor said, if you have sex with someone who makes sperm, you'll need to use contraception to prevent pregnancy. This picture is taken at the celebration that we had when he received his new name and new gender paperwork from the state. Later on, we had an appointment with the speech clinic. He has an underlying neuromuscular condition that was affecting his speech. And in addition, he wanted some help with the lower register difficulties he was having with testosterone. And the therapist said to us, to quote, testosterone is harmful to the female developing vocal cords and will cause permanent damage. And it is wrong for her to provide Quinn with speech therapy that could harm his, quote, female vocal cords. There were multiple religious symbols throughout the office, and we wondered if these represented her underlying bias. Given the well-documented historical oppression by religions and religious institutions towards LGBT individuals, if you do have these symbols present, I'd highly recommend that if you are affirming, counteract these with affirming symbols, as your patients may find these threatening. We had an appointment with Pulmonology Clinic, also for follow-up for his neuromuscular clinics, for his neuromuscular issues, and he had a follow-up spirometry exam. He had his binder on and had a restriction in breathing that was significant. I knew that Quinn was uncomfortable with me outing him at this appointment, and there was a large team, multiple medical students and residents, and the fellow and the attending, and they were unaware that he was binding, and I don't believe that they were aware that he was trans either. So I didn't out him, and there was a key piece of medical information that went unknown to the team. We followed up later that day with this Gender Health Clinic family med doc, and I shared this information with her, and she turned to me and said, it's essential that you start looking for a top surgeon at this point. And now to that point, Quinn was under the impression from his research that he was not eligible for top surgery until he was 18. And I had not disabused him of that notion. But Josh and I had thought probably along the age of 16 was when we would consider it. Our health insurance was explicitly excluding all transgender care. And so everything was out of pocket that we were paying for his care at this point. And top surgery is expensive. We could afford cash pay for outpatient surgery, but with his neuromuscular condition, he had needed an ICU stay for a simple muscle biopsy. And top surgery was more invasive than that. And we just couldn't chance, obviously, we couldn't afford an ICU stay for cash. And also, he was 14 and we weren't ready to look at an irreversible surgery at that point. But this was something different. And so I turned first to a Facebook group of physician moms with transgender kids. I got some support that evening from there. And then turned to a top surgery group online. And this was a group made up of non-binary and transgender folks who wanted top surgery. And not everybody does, but these were people who did. And read through the stories there, and there were a number of people who wanted surgery, and then many people who were sharing their results either immediately after or years after from surgery. And reading through their stories, I realized just how important it was for the people who did want surgery, and Quinn had wanted surgery from day one. And it was just really eye-opening for me. And of course, did all the medical research and all of that as well. But that night was really transformative for me. And I learned that we were in the last week of covered California availability. And so hit the ground running, trying to find what we could do to find out if Quinn was even eligible and to get him coverage so that we could explore this further for him. And so we did the research and decided that Kaiser was his best option, and enrolled in Kaiser. And over the next year, went down the paths that were necessary to explore that. And due to time limitations tonight, I won't go into that in this talk, but I'll flash forward to October 2020 at age 15 when he had his life-changing surgery. And this picture was taken a day or two after surgery. And I think you can see the confidence that he exudes here. He describes and just has so much confidence after this. And what he describes is body euphoria now, instead of the daily body dysphoria that he lived with before. This is the letter he wrote his surgeon afterwards. It says, "Dear Dr. Bellick, it's hard to put what you have done for me and countless others into words. A mere thank you is not enough. I've been up to this point only been about 50% okay with me. And you know what you did? You gave me self-acceptance. You've given me the ability to start learning to love all of me and so much more. So thank you, thank you." So I'm going to stop there with that part of the story and turn to some of the common issues that face trans patients. Bathrooms are always a hot button issue and have been in our country, more so for trans women. There are numerous safety issues. And when Quinn was transitioning and his gender didn't match his appearance, I was certainly very concerned whenever he used the bathroom. For some of his peers, have had recurrent UTIs because of withholding when they've been out. Locally in California, we have the requirement for single stall public restrooms to be labeled unisex. However, you can see the smaller symbol is the gendered, still follows the gender binary with the male and female symbols. And in looking at our local hospitals, the majority of them still label those bathrooms with the gender binary. And so I would encourage everyone to advocate at your hospitals to have those changed over to either include only the triangle symbol, which is the California gender neutral symbol, a universal gender neutral symbol, or if the hospital feels they have to include a sign, then include the all gender restroom sign. Forms, I think, are critically important. And had these registration forms been done for Quinn at the emergency room or at his pulmonology clinic, then his care would have been very different at the ER and at the pulmonology clinic, and care would have been different. The EPIC sexual orientation and gender identity form is known as the SOGI form, and this covers everything. Patients preferred, I don't like the word preferred, it's patients' pronouns, but patients' pronouns, gender identity, sex on original birth certificate, sexual orientation, genders of sexual partners, and then organ inventory, organs that the patient currently has and organs that are present at birth or expected at birth to develop. So that covers everything you need for medical care as well as for preventive screening. And this, I believe, should be done for every patient. On my recent visit to UCSF for an eye issue, my registration a couple of days ahead of the visit for my UCSF registration included this as a computerized form that I had the choice of filling out beforehand so that everything's taken care of. Now, at Sutter, unfortunately, this is hidden under the rarely used forms as a transgender identity form, which, as you can see, it's not actually a transgender identity. It covers everything. But once you do use this form, it will be loaded in your commonly used form so that you can access it more readily. Quinn had some additional thoughts he wanted me to share, and he wrote an article for my webpage, which is there, called Creating a Transaffirming Medical Space, and it covers all the different ways to do so. He also emphasizes tossing out your assumptions. Trans people are diverse, and there's no right way to be trans. Not everyone transitions medically or surgically, and someone who is trans who chooses not to have medical or surgical treatment is just as trans as someone who has full transition. Only ask questions when you're seeing a patient if it's relevant to treatment. If he has a broken bone and they're asking if he's going to get bottom surgery down the road, he's well aware that that person is just satisfying their curiosity and that it has nothing to do with the treatment of his broken bone. And that feels invasive to him. Many trans patients deal with dysphoria, and a fair number have a history of trauma. And so consent and sensitivity around exams are very important. Explaining, obviously obtaining consent, explaining the steps, using patient terms for body parts can help with dysphoria, and then being trauma informed. And then educating yourself, curating your social media, reading books by trans authors. And I want to draw your attention to a great article in this month's New England Journal of Medicine by non-binary physician Dr. Streeter about their experiences with the match, which I thought was excellent. I'd be remiss if I didn't talk about our experience as parents. We, of course, just had a tremendous desire to support our son in being himself, and a lot of pride in him for being able to verbalize and articulate what he was feeling and be able to just do this at this age. We also had a lot of fear and anxiety about discrimination in healthcare, as I've explained, in our family and in the world at large. And then awareness about our privileged position. We live in a state that has a lot of protections in place against discrimination, as opposed to some other states that are actively pursuing laws that discriminate against transgender patients and people. And awareness about our privilege in having the financial resources to be able to afford to help our son transition, and awareness about even something like our race, that transgender people of color have so much more discrimination and much worse outcomes. Within the support groups that I'm in, the common experiences that I've witnessed include things such as guilt, that parents have raised a transgender child and a feeling that they've done something wrong, a sense of sadness and a sense of loss at having lost the child that they thought they had, as well as a loss about future experiences that they thought they were going to have with the gender child that they had, whether that's a prom or a wedding or whatever that future was that they envisioned with the gender of child that they thought they had. There's a lot of denial and saying it's just a phase. In the experience we had with Quinn, where he initially came out as non-binary and then very quickly came to change to transgender, it's very common for teens to go through several different identities. And I personally think it's really important just to support kids as they go through those. And our job as parents, I think, is just to support, and it doesn't really matter where they land as long as we're helping them and they know that we've got their back through that. And then I see a lot of refusal to use teens' names or kids' names and pronouns. And I can't stress the importance of that enough. I've got a couple of slides to emphasize support. If you have parents there, please do emphasize this. Trans and non-binary youth who report having their pronouns respected by all or most people in their lives attempt suicide at half the rate of those who do not have their pronouns respected. And those numbers are 28% versus 12%. This was the 2020 Trevor National Survey. And you can see those numbers decline depending on the number of people who are supporting them. Parental support, additional numbers for those who have people in their life who are attempting to convince them to change their mind about sexual orientation or gender identity. 19% of those youth are attempting suicide. And for those who have no one attempting to convince them to change, only 8%. And then I also wanted to point out the statistics. For those youth who do not have access to binders, shapewear, or gender-affirming clothing, 26% will attempt suicide, versus for those who have access to most of those items, 14% will attempt suicide. So parental support really makes a huge difference. Last, I wanted to go over some resources. Locally here, we have the Sacramento LGBT Community Center and the Gender Health Center, which both provide a wealth of resources for us. The LGBT Center has, they both just have a bunch of different resources. PFLAG has great support groups. This transgender teen support, I think everyone here should be reading. It was one of the first books I read cover to cover. I find a lot of value in reading fiction and nonfiction accounts, personal accounts for understanding things. And then I put together a resources handout that goes through resources for clinicians, resources for parents, teens, BIPOC resources, local resources. There's a Google document here that includes clinicians who are known to be trans-affirming or gender-affirming and who prescribe. If you are someone, please email me your information so that I can include you on this. This is used by some local schools as well as clinicians and support groups, and then books that Quinn and I both found helpful. And that should be available to you in the chat room as well.
Thank you, Dr. Mcilnay. We really appreciate you sharing your story. So next up, we have Dr. Christopher Swales. Please take it away.
All right, so I'm going to go over a little bit more of the health disparities and some of the things that clinicians can do. So first of all, I just want to make sure we went over some definitions. So some things to understand. So gender is your internal sense of self, right? So that's how you feel on the inside, whether you feel more feminine, masculine, in between, outside, that's your internal sense of self. Sex is generally is used as biologically assigned at birth, what the organs that you have when you're born. Gender expression is more of the external presentation of gender, right? So, in that gendered era, if you're wearing, dresses and long hair, that's more of a feminine presentation. So gender expression is that external presentation of gender. Sexual orientation is who you're attracted to, right? So this is not anything to do about gender or anything like that. This is who you are attracted to sexually, physically, those kind of things. So the term transgender is most easily understood as when the gender, the internal sense of self that you feel on the inside, and the sex that you're assigned at birth are not the same. They're not congruent. Okay. That doesn't mean they have to be binary, right? You don't have to be assigned male at birth and feel female. You can be assigned male at birth and mostly feel male, and sometimes female, sometimes more female, feminine, those kind of things. So it is very much a spectrum for that. And then gender nonconforming, it kind of speaks to that more, where it's just you don't conform to what we consider the binary, right? So you are somewhere in between, outside, wherever you feel for that. And then gender expansive, I might say this interchangeably, but gender expansive is just a catch-all term. So, rather than just saying trans resources or non-binary resources, gender expansive just means an expanded view of gender, that sort of thing. Okay. So the places to look that have really good clinical information, as well as other resources too. So UCSF has a pretty good online resource for clinicians. So you can Google search it. It has for UCSF Center for Excellence. They have a clinician clinician page and also patient-facing page. The clinician page goes through pretty much everything you would ever need to know for clinical work for the most part. It goes through feminizing therapy, masculinization therapy, non-binary, goes through medications, how you do it, all sorts of stuff. So it's a pretty good resource, and I look at that quite a few times to get an idea of if there's anything new or different that's been going on. And that's available for free. The WPATH is the World Professional Association for Transgender Health. They have currently a version 7 standards of care, and this is the standards of care that are accepted by the American Medical Association, the World Health Organization, and most of the major medical societies as the standards of care for gender expansive folks. So this goes through, hormone therapy and surgeries and all this kind of stuff. Now, version 7, I believe, was done in 2008. So it's a little old, and you can tell because there's still things like you need 2 letters from a psychiatrist and a counselor and another letter from your doctor, and all these kind of things that are kind of requirements that seem unnecessary at this point, but they are still there. So if you are a physician working with trans patients or gender expansive patients, you want to know, because this is what a lot of or most insurance companies use as a guideline for approving or doing surgeries, hormones, those kind of things. So it's good to know about that so that you can be aware of what they may require before approving things like surgeries. All right. Now the WPATH is supposed to be updating their guidelines. I think COVID threw a big old wrench into that. So the version 8 should be releasing sometime. I was hopeful that it would come out in the winter here, but I'm not sure if it'll come out. But those are the WPATH. You can become a member, you have to apply, all that kind of stuff. But the standards of care are freely available to everybody. You can download it. I've printed 2 copies. I have them in my office for medical students and everyone to look at if they need it. All right. So there was a 2009 survey. So a lot of the data for transgender affirming care, those kind of things, is sometimes a little not spotty, just not a lot of it for many reasons. One is that gender expansive folks have commonly been traumatized, kicked out of medical systems, have had a really bad relationship with medical care for the most part. So there's a lot of distrust on that end. So trying to convince patients to do, studies, that sort of thing can be difficult. Also, just sample size, right? So there are several surveys that we'll reference that are kind of how we get a lot of this data. So Lambda Legal did one in 2009 that partnered with groups across the country to survey over 4,100 both LGBTQ plus and HIV positive patients on their experiences and fears with the healthcare system. And I think that I really like this one simply because I think it's important to get a perspective from the other side, how they are feeling about things. So for example, the question was, I was refused needed healthcare. So a quarter of transgender patients responded that they were refused, right? Whether that's, from their perspective, they believe they were refused needed healthcare, and about 20% of HIV patients. And 50% of trans respondents felt that they would be refused medical service if they asked for it, which is huge. It's half the number of people. And then almost 3/4 of trans folks and 35% of the HIV and so a quarter of the LGBT respondents felt that the medical personnel will treat me different if they know what I'm asking for or know my status. And so, 3/4 of trans folks are going to have a lot of fear coming into a physician's office or any sort of medical system because of all of this, because of the history and the historical stuff that's been going on. And then obviously the last one, not enough health professionals adequately trained. This is 90% of trans folks, which makes sense, especially in 2009. We've just barely started doing some of this training in medical schools, especially even here in California. I think UC Davis has only started to include this in the past couple of years as part of their education for their medical students. I certainly didn't have any training in medical school or even residency. There was nothing. And so about 50% of HIV and LGBT patients also felt that there was not enough adequate training. So, you add all these things together where they fear they're going to get refused service, they're going to be treated differently, and they don't have the training. And it means that people, trans patients and other gender expansive patients are going to go elsewhere. They'll go online, they'll buy things off the street, they'll do what they can because they know what they need, and they're going to go pursue it. But we want them to do it in a healthy and safe fashion. So we need to be able to provide that for them. So the medical education component is definitely really important. And this is where I applaud UC Davis for adding it into their curriculum. So as you can see here, this is from 2016 endocrine diabetes, wherever that place is from. So the biggest barrier is safe hormonal therapy and appropriate general medical care for trans patients. So not having people who understand, right? So as the previous story showed, not being aware can lead to problems in diagnosis, right? If you don't know someone is trans and binding, you may not get a correct FEC or other PFT results, right? So if you don't know someone is trans and you're asking about other things, you may miss that. One of the things I always remind my trans patients or other gender expansive patients is, if you have changed your gender on your official documentation and everything, whatever organs you have to make sure that you're doing the appropriate screening. If you're a trans man and you still have a cervix, you still need to get cervical cancer screening, right? But if you are in an office and listed as male and nobody asks and you don't feel comfortable giving that information out because it doesn't seem like a welcoming place, you may not do that, which means you may not get your cervical cancer screening and miss something. Same for trans women. You still have a prostate even after surgeries. So you still need prostate cancer screenings, those kind of things. So being aware and open is important. Okay. Sorry, this typing got very small apparently. So, young patients find it difficult to report their sexual identity. This is from 2017, so not too long ago. And this includes all of LGBT, but definitely the gender expansive patients are more specifically. So 68% of sexual minority youth reported not discussing their sexual orientation, and 90% said they have reservations about reporting them. So how are we supposed to talk to the younger folks about safe sex practices, or, say being safe in a relationship, these kind of things that are really important for developing kids and teens and adults, right? If they don't feel comfortable revealing that, right? So if you are, I was trained just to ask, are you having sex? How many partners? But really it should be, do you have sex with someone who has a penis or vagina? Those kind of questions. And a lot of people feel uncomfortable asking, but you got to do it. And you have to make sure that they feel comfortable with answering. There was another smaller study that they did some audio interviews and were following these 9 women between 18 and 24, and they did the audio interviews that disclosing the sexual orientation that negatively affected their experience. So the lack of training can strain the therapeutic relationship between the provider and patients, and that's really one of the most important things, is to build that trust and have that trust between you and the patient, so that they are able to express their needs and their concerns to you, and that you are able to then take care of them appropriately. And that's really important, right? That's what we do. The patient, the physician-patient relationship is most of our work, especially in primary care. It's not clicking buttons or ordering tests. It's talking to the person, knowing them, and allowing them to feel comfortable to express their concerns to you, because otherwise they're not going to, and we might miss something until it's too late. Right. So this is where it kind of, and it's already been kind of pointed out as well. So 40% of trans and gender expansive patients have attempted suicide. And so I think it's really important to understand that minority stress, which is this idea of cultural and social prejudice attached to minority sexual orientation and gender identity, and institutionalized discrimination. So laws, public policies, all the stuff you see on TV, all that stuff, that's what really puts the pressure on trans and gender expansive patients. It's much less going to be the internal stressors from the sexual orientation or the gender that they feel on the inside that cause that. Now, there still can definitely be stressors from that themselves, but a lot of it is from these external stressors, right? I mean, can you imagine if you constantly were seeing on the news people debating whether you existed, whether you should be able to go to the bathroom, whether you should be able to participate in sports, those kind of things. If that's all you hear all the time, that's incredibly stressful. How are you going to live your life? If you want to be an athlete and you're trans, what is that going to mean for you in the future? And that can cause a lot of mental stress, and it does. So, and that's where a lot of the suicidality will come from. And that's not all of it, right? There's still traumas, experiences, all this other stuff, but that is a large part of it. Okay, so what can we do? So using respectful language and the correct names and pronouns is a really big one, as Dr. Mcilnay has said before. So, this is where if someone tells you, I prefer this name, or this is my actual name, or tells you their gender, their pronoun preference, you need to use those, right? Those are what they have expressed to you. It's no different than, if someone's name is William, but they ask you to call them Bill, right? That's what they go by. That's their name is Bill, not William. Not exactly the same, but as close as you can get to kind of compare. So using that language and asking is even the next step, right? So when you talk to someone, you can ask them what pronouns do you prefer. I do that with all the patients who come in for gender care. I should really do it for everybody. Even me, I'm still not in that habit yet, but that is a really good way to do it. The other way is to have, I know the UC Davis folks have pronoun preferences that they can put on their tags, something like that, where, on your ID tag, it'll say, Dr. Swales, and underneath he, him, something like that, that can show that you're aware at least of pronoun preferences, and they may feel comfortable bringing up to you. So as we've seen before, those experienced depression, suicidal thoughts were less likely to have a provider that treated them with respectful language. Okay. And then that's step one, is just treating people with respect, right? You'd expect that. The next step is then for the physician component is to give hormone therapy and access to gender confirming surgeries. I mean, that's what we're here for as physicians, really, is to treat what the patient needs, and what the patient needs, especially for gender expansive folks, hormone therapy and surgeries, if that's what they want. And there's no right way of doing this. Some patients don't want to do hormone therapy, but they do want to make sure that they have top surgery. Their breasts are just causing them problems and they want to get rid of them, but they don't really want facial hair and changes to their voice and all this stuff. There are some patients who want everything. That's great. And some patients who really just want some of the body changes from hormone therapy, but they're okay. They can bind, or they're not as bothered by some of the organs that they have on their body. But doing that hormone therapy and the surgery component significantly lowers things like tobacco smoking, suicidal thoughts, those kind of things. So it is a very important component of treating these patients. Okay. So I always include this slide whenever I do presentations. So creating a safe and welcoming clinic is really important. And this is where, as physician leaders in the clinic, we can start to potentially make some changes, right? So the idea of cultural humility is meeting patients where they're are, not where we think they should be or where we think they are. And this is really hard for me. I grew up in the South, so sir and ma'am is pretty much automatic for me most of the time. So unlearning those habits, right? Because you really can't assume someone's gender based on what you're seeing, right? You have to ask. So gender neutral language is really important. You can use they, them if you don't know what the pronouns are. You can say patient or person instead of anything else. For a lot of folks, sir and ma'am is kind of that really respectful language, but not for these patients. So, it's something that you just kind of have to unlearn, or really focus on, being very cautious with how you use that until you are sure of what their gender might be. Right? And then if they're okay with it, then you can absolutely use that. So using the correct gender pronouns if known and indicated by the patient. This is where those intake things can come into really good play, right? So to let you know ahead of time, asking patients ahead of time if they correct you, saying, nope, I'm sorry about that, and moving on and using it correctly in the future. And then the correct name, which is can be different from the legal name. And that's really important because, for a lot of the health systems and for a lot of the EHRs that we use, you can't really change their official name or their legal name until lots of steps, right? So for us in our medical record system, we can't change the name until the ID and the insurance card are the same, right? Until they match, because then when we send it to the insurance, if they don't match, there'll be problems. So I usually tell patients ahead of time, and just so they are aware, so that they know I'm thinking about it. And I say, listen, I can't change your official name in the chart until these things are happened. I'm going to put a reminder in. I'm going to do our best so that the clinic is aware of your correct name, and so that we can use that. And you can feel free to correct people if they use the wrong name, because we have also done education for our staff and everything like that. So, recognizing it, letting patients know what you can do, what you can do to help with some of these things that can't change. We have a reminder system. I think some of the other medical record systems have a preferred name or like a nickname section, something like that. That can be more useful. So just setting them up to know what they can expect also helps them to understand, okay, someone used my name wrong, I should correct them, or I'll let Dr. Swales know later. As was indicated before, patients are there for care, not to educate you. So I was really lucky. My first experience with a trans patient was seeing someone that had been to one of our other clinicians in the office who had a very bad experience with that clinician. Lots of misgendering, why do you want cut your breasts off? These kind of really very bad experience. So that person came to me expecting, they were very nervous. I could tell. They even said it, and they came with a bunch of packets, lots of information from like the trans line, other places that they had found on the internet. And I had read the chart a little bit ahead of time, so I knew what was going on. So I told them, listen, I am here to support you, and I will let's do this together. I will find out what I need to do for your care. You don't have to tell me. That's not your job. So, that's when we go in, we look it up, we read about it, educate ourselves so that the patient is there to be a patient, not to be an educator. And that's a really hard thing to kind of resist, is to ask them. I mean, they are experts, right? But they're not necessarily really experts. They're just people who are looking for care that they can't find. So it's really important when you're seeing a patient, you gauge how much they are willing to help, right? But really it's up to you as a physician to educate, get some information, figure it out, and let the patient know, like, hey, like I did with my first couple of patients, I told them, listen, I'm new to this, but I've looked at it. This seems to be what we do. So I'm going to work with you on this, and, we'll work together. You're just the patient. We'll get you the hormone therapy. Let me worry about the lab work, and I'll find out that stuff for you. So that's a big component of it. And then staff training, right? So for anyone who touches patients, they all need to be trained, right? It's not just your physician and your MA. It's the call center, it's the lab people, it's anyone who might have to call out their name out loud or interact with them personally, need to have some education about gender expansive care and taking care of these patients. So even if it's as simple as, hey, look in the chart, see what their pronouns are and try to use those, right? Don't actively use it, but training for everybody who might touch the patient is very important. Okay. And then, as indicated as well, so gender neutral restrooms, really important. So if it's single stall restroom, there's no reason for it not to be gender neutral. I actually didn't know there was a law that it had to be in California, which is fantastic. But the other big part, if you have multi-stall bathrooms, is to really advocate for a sign or signage that says, use the restroom of your gender identity, or something to that effect, so that patients feel comfortable using the bathroom that they of their gender identity. Okay, not talking too fast yet. That's good. So this having a welcoming clinic is important, because that, when patients come in, if they can see some signs or some things that tell them that this is welcoming, when your front desk staff says, doesn't use gendered pronouns, or may ask you your preferred name, gender, those kind of things, that increases that comfort level, and really puts patients, kind of lets them know that there is some safety here. And that's really the important part, is to let them know as patients that there is safety, right? Because otherwise, as we saw from the surveys before, patients have a lot of concern, a lot of fears about coming to a doctor for lots of really legitimate reasons. All right. I think the other point is, as I stated before, patients come in for all sorts of things. Sometimes their trans care or their gender status might be important, and it's important to discuss that. Most of the time, it really won't matter at all. So, knowing that they're trans and using the correct pronouns is good, but if it doesn't involve any of that, you don't need to ask anything about it. So really focusing on the disease or whatever is happening for them. On the flip side of that, for some needs like overactive bladder for trans men, prostate issues for trans women, it's really important to have that level of trust, so you can have that important discussion and really go through with them, figure out where their comfort is. Have they had bad experiences? What can we do to make it better? Knowing who in your referral network is sensitive to gender expansive patients, who you think or can trust will treat them with respect, because bad experiences elsewhere can reflect badly on you, and you want to keep that patient provider relationship intact. So, I have a couple OBs in my group who I know are very, very good with my trans men. So I always send them over there, because that provider does a really good job of treating them very non-gendered and with a lot of respect, and they really appreciate that. So it's good to know who you can send people to. Right. And really going through, and this is where, when you get to really sensitive topics like OAB and other topics like that, that's where you have to have a lot of that sensitivity. And if you're, say if you're an OB/GYN provider, talking with patients ahead of time, explaining what you're planning to do, what it involves, and ways that you can help them feel more comfortable, whether that's using different terminology for specific body parts, or having someone with them or anything like that. For trans men, the testosterone can cause atrophic vaginitis. So talking with them about that and ways to help improve that so they don't have pain or discomfort. Those are the kinds of discussions that take that level of trust to do. Okay, and I always include this because I really love this. National Geographic did a bunch on the gender revolution. I think this was 2017. This quote down here for on the, I think it's left side. The best thing about being a girl is now I don't have to pretend to be a boy. And I don't have any, I think that kind of helps to understand what it must feel like. There's no way for me to know really, because that's not an experience that I have, but just trying to imagine, what if I had to play the role of, a different gender for all of my life, and every expectation that was put on me was based on what I was wearing or how I was expressing myself. Just the stress of having to constantly live a different life than what you want or what you expect or what you desire is very, very stressful. And I like this other one because it has, includes all sorts of different gender expressions and identities, the androgynous, the trans man, bigender, all those kind of things. So this is starting to become more and more, as we know, into the social discussion. And honestly, as physicians, we have to follow, kind of medical guidelines and the data that we have, and all of it points to being supportive of patients' gender and gender identity. I think that's it. I won't go any further. So I don't know if anyone has any questions, but I'm gonna stop talking for a second. How about that?
And it was not too fast, Dr. Swales. Nice job keeping pace. So I've been monitoring, and honestly, you guys have been so thorough. I was thinking, do I have any questions? And I normally do, but you really covered so much. So to give people some time, if they do have any questions they'd like to ask, I'll talk about something else for a second. I want to remind everybody that September is Wellness Month with Medical Society. We have a ton of activities planned for this month, really to support you all physicians. We have a month-long walking challenge that starts today. Tons of great prizes. We also have our Joy of Medicine Summit. Well, we'll have talks like this that are worth CME credits, and that will be on Saturday, September 25th. And I'm actually going to throw the links to both of those in the chat. And let's see. Yes, so there is a question. Annie says, that was great. How can we educate more providers around the country with this important information?
So, I mean, from my standpoint, is anytime you encounter, on Facebook groups, online, anywhere where there are questions, or you notice people having, probably the wrong idea, just constant education, right? So there's not a whole lot of really big groups that you can go to. That there are gender conferences, that sort of thing. But really, the best thing that you can do is one-on-one conversations. That tends to be what changes people's minds or helps them educate them the best, is a non-judgmental, hey, listen, you had said some of these kind of things, but let me share with you my experiences with my patients, and here's, if they're, physicians, data sometimes speaks as well, but to really talk with them about how that feels, what you've experienced, because personal stories work better than data for changing people's minds. And physician to physician talk, right? If I talk to other family medicine docs and say, hey, listen, this thing is really important. One of the experiences I had when I was doing grand rounds with Mercy Medical Group is I did have a physician who asked, well, how do we know it's not a delusion, right? I 80 years ago or whenever I was with psychiatry residency, and how do we know it's not that? And those are the kinds of things you may experience, and really, both knowing kind of what delusions and other things are, and then explaining like, hey, listen, the American Psychiatry Association, it's not a disease, it's been taken off, this is just something that needs to be treated like anything else, those kind of things. So one-on-one conversations for me, I think, is going to be the best, and just really encouraging people to listen to some stories. It's all you, Kim, if you have
Dr.
anything.
Mcilnay, did you want to add on to that?
Yeah, I agree. I think the one-on-one is great. And
Okay. All right, another question. Any suggestions to help parents be more affirming for those who aren't supportive of their transgender, gender-expansive child? This has been very challenging.
so I encourage for clinicians who are working with the parents, encourage them to seek out these resources, get plugged into support groups, learn as much as they can so that they can understand the importance of support. And I think with education, they can, once they understand how critical that support is, it becomes very easy to support their child. If you are the parent, I think reading, or Facebooking and joining supportive groups. There's a long list of support groups or support ways of gaining that support that I've included on the resources list. Whether you prefer virtual support or in-person support that are included on that. And so choose your chosen way of learning, but there's multiple different ways. There's even a podcast on there so whatever your avenue of learning is, choose that and learn as much as you can. I think knowledge is power here. And then listen to your kid and, ask questions as much as they'll answer. Not all teens will answer.
So for Annie Gardner, the big medical conferences, including content on creating a gender-affirming hospital office. I don't know of any specifically, but I do know here in California, I've gone to it multiple times. It is pretty good. It's the Gender Spectrum Conference. They usually have one day that is more for clinicians, more like a CME type thing. And then they do a weekend that is for everybody, for parents, teens. They do a lot more stuff with that. UCSF has information. And then there's another place I went, but the Gender Spectrum Conference is the one that sticks out for the most, because they usually do have like a legal person, someone to talk with about how to do stories, that sort of thing.
UC Davis
So
had a
along those, I'm sorry, go ahead. Along those lines, are there training companies that you can recommend who lead staff training in your medical group?
The Gender Health Center, I believe, or used to, everything with COVID has been a bit weird, but Gender Health Center can do trainings. They who UC Davis used when we were doing third year, fourth year medical students doing fake patients, that sort of thing. So the Gender Health Center, I believe, does training.
Okay.
Kim, you were saying something about else about other.
UC Davis has an outcome conference every year also. And two years ago, they did quite a bit on transgender patient care, or I guess last year even. So every fall they have a conference also.
Let's see.
And there's one more in here. I've been looking for a support group of other parents of trans teens. Would you happen to have any that you would recommend?
So currently, there's a long list. I don't have one that I'm currently in to personally recommend, but the ones I checked out early on, PFLAG has one, and that resource list that I included has the list of them. PFLAG has one locally, and they're running virtually right now. The Trans Family Support Group down in Southern California, transfamilysos.org, they run a virtual group. I know the Proud Clinic in Oakland is opening up one. I don't know if that's patient only though.
I think Rainbow Families, there's YOLO Rainbow Families in Sacramento. Rainbow Families is they're smaller groups, but they're for parents and families who have gender expansive kids, I believe.
Okay. Well, thank you both so much for sharing your stories and for these just really timely presentations. Just a reminder for tonight's webinar, it's worth 1 CME credit. And tomorrow you'll receive an email with a survey link. After you filled out that survey, your CME certificate will be emailed to you, and you have 1 week to fill out the link in order to receive your credit. Again, tonight's presentation will be available on demand for CME credit through Wednesday, September 8th. We'll host the video on our YouTube channel. So with that, I hope everyone has a wonderful evening, and we look forward to seeing you all at the next health equity webinar that will happen sometime in November. So to be determined.